Welcome to another episode of the PFC Podcast. The opinions you hear are ours and doesn't necessarily reflect anyone else's. Now on to the podcast.
All right, well, my name's Rick Hines, and today I'd like to speak to you about sedation and anesthesia in the prolonged field care austere environment. First off, who the heck is this Rick Hines guy, and what gives him the right to talk about anesthesia? Well, I spent 29 years in the Army, a bit over 21 of that as an SF guy, an 18 Delta, team sergeant. I've had a few deployments, combat and otherwise. I've been sent to remote areas, seen some crazy diseases, a bit of trauma. I've even had my feelings hurt a time or two. I retired at the end of 2016 and have been a medical instructor ever since. What I want to talk about are techniques, and some may be controversial. Please defer to your medical protocols. My goal is to introduce some ideas from my experience to drive further discussion. Some of these techniques vary from the prolonged field care clinical practice guidelines. This is just a knuckle dragger's perspective, having had the benefit of working with some folks far smarter than I. All of the opinions in this podcast are mine and don't represent anyone else.
Yeah, why is this important, and why did I decide to dig into this and study a little bit more on this? Well, essentially, I almost killed one of my guys. Not on purpose, obviously, but we're on a patrol, vehicle hit an IED. We lost one guy, had two seriously injured, and one of the guys I treated at the time, we weren't carrying injectable fentanyl. We had the lollipops, but we carried morphine, and I gave him morphine for pain. And later on, after he got medevaced, he went into surgery, and I found out that he almost died. His blood pressure tanked, and I figured that it was probably the morphine that I'd given him. And so when I got back, I pulled the CRNA aside and said, hey, man, let's check our pride here and tell me, how can I do this better? How can I get smarter on this? And from that point on, we started working together, and I learned a lot from him, and that's where that's kind of how this all came about.
So with all of that out of the way, let's ask some questions. What is anesthesia? According to Merriam-Webster, it's the loss of sensation with or without the loss of consciousness. What is analgesia? Again, Merriam-Webster says it's the insensibility to pain without loss of consciousness. Okay, so what is amnesia? A loss or a gap in memory. And finally, what is akinesia? It's the loss or impairment of voluntary activity of the muscles. So why do we need to know all this? There are times when we want to sedate our patient to alleviate anxiety, but we want them to be able to protect their own airway. Other times we may want them on a surgical plane. This is anesthesia. If we're going to do a painful procedure, we'll want to alleviate the pain. This is analgesia. If they are hemodynamically unstable, we may want them to have a bit of a painful stimuli to keep their vital signs up. If you do this, you want something to take away the memory of the painful event. This is amnesia. During surgery, we don't want the patient to move. For this, we use paralytics. This is akinesia. This is all part of anesthesia. I'd like to introduce a term that's relatively new to me, but some of you may be familiar with: autonomic stability. To explain this, remember that the autonomic nervous system has two components: the sympathetic, the fight or flight, and the parasympathetic, the rest and digest. Most of these systems work together by giving the vascular system a certain tone. This is why our heart rate and blood pressure stay about the same when we're standing or laying down. If the parasympathetic discharges, we see a dramatic hypotension or a drop in blood pressure with bradycardia, a slowed heart rate. If the sympathetic discharges, we see tachycardia, an increased heart rate, or hypertension, increased blood pressure. Autonomic lysis or autonomic stability is making sure neither of these two systems discharge. This is important, especially with a trauma patient. The sympathetic is what is keeping them alive. That stimulation increases their blood pressure and their pulse. It also gives them systemic vascular resistance. If we're too heavy-handed with our induction dose, including ketamine, we can knock out this system and lose our systemic vascular resistance, leading to pulseless electrical activity. That's not cool. So tread light as lightly as possible with induction. Let's back up a bit. I'd like to speak about the drugs some of us use. Most of us carry ketamine. I prefer the 50 milligram to 1 ml. We also carry midazolam, otherwise known as Versed, 5 milligrams per ml, and some carry fentanyl injectable, not just the lollipops, but the injectable, the 50 micrograms per ml. IV propofol is a great drug, and you'd think this would be right up our alley. It has a rapid onset, less than a minute, and a short duration, 3 to 10 minutes. However, many of our patients are hemodynamically unstable, and propofol can drop their blood pressure pretty quickly. This is a drug that requires someone to closely monitor the patient, as we're often both surgeon and anesthesiologist, and I use these terms loosely. It would be dangerous and cavalier to use this drug without a competent person solely running anesthesia. Plus, the manufacturer recommends storage of 40 to 72 degrees Fahrenheit, and we're often outside this range. And once you tap the container of propofol, you have less than 12 hours to use it. Bacteria grows in this stuff like crazy. At times, we carry vecuronium, or VEC. You can carry rocuronium or succinylcholine, but I prefer vecuronium, 10 milligrams per ml. And we use this for rapid sequence intubation, or RSI. Succinylcholine is short-acting, which is great, but the reason I prefer VEC is I can use it for more than just RSI. I can use it for ventilator compliance with a patient with blast lung or pulmonary contusion. But remember, this is a paralytic. It'll paralyze his diaphragm, so something or someone needs to breathe for them. Ventilators are another podcast. Rocuronium requires refrigeration or it loses its potency. So I don't recommend carrying that. If you're carrying VEC, make sure you have your reversal agents. Neostigmine at 0.03 to 0.07 milligrams per kilogram IV, and either glycopyrrolate or atropine. I prefer the atropine at 0.4 to 0.6 milligrams IV. The reason I prefer the atropine is I can use it as a pre-surgical medication to dry secretions, increase the heart rate. It has a cardiac application for treatment for bradycardia or PEA. It's also used as a nerve agent antidote along with midazolam. Another reversal agent, a newer one, is Sugammadex. It's the current reversal agent for VEC and ROC in most hospitals. If you can get this, it's a great option. You want to administer this at 2 to 4 milligrams per kilogram IV. A good rule of thumb, if you use 20 milligrams of VEC for RSI, I'd recommend 4 milligrams per kilogram of Shug just to reverse or to use it as a reversal agent. Also, since we're carrying opioids, make sure that you have Narcan, 0.4 to 2 milligrams. You may need to repeat the dose every 2 to 3 minutes as Narcan burns off quicker than most opioids. Then there are your local and regional anesthesia agents such as lidocaine, 1% with or without epi, lidocaine 2% with or without epi, Marcaine 0.25%, ropivacaine for long-term blocks. You can see the lidocaine 1% is 10 milligrams per ml. The lidocaine 2% is 20 milligrams per ml. This makes the math a bit easier. Finally, we should all carry Zofran. You want it oral and injectable. I won't get much into antibiotic or fluid therapy, as that would keep us here way past OBEER 30. Let's set up a scenario. You have an injured patient in significant pain. Evacuation time is unknown. Let's not list a bunch of imaginary wounds, and let's assume that we're Johnny Trauma and all the trauma treatments were done splendiferously. Fentanyl lollipop and TXA, tranexamic acid, if applicable, have been given. Now we have some time to come up with a pain plan. So ideally, before any of this happens, we would have time to do our pre-anesthesia evaluation. However, this isn't always possible. Often we have whatever is brought to us. So before we start anesthesia, we have to be able to monitor our patient. The minimum monitoring capability you need is monitor respirations, heart rate, blood pressure, and pulse oximetry. The best would be to have all the above with a 12 lead, end-tidal CO2, capnography, and if you got an arterial line to measure mean arterial pressure, that'd be ideal. Oh yeah, you might want to record the vital signs so you keep track of trends. A technique that I recently learned is to, as far as tracking pain, is to look at the patient's respiratory rate to determine if the unconscious patient needs pain medications. If you see the respiratory rate rise above 12 per minute, 12 respirations per minute, they may need some pain medication. Which pain medication will depend on what you have and how hemodynamically stable they are. We'll start with anesthesia and a stick. With the concentrations mentioned earlier, take a 5 cc syringe and draw up 150 milligrams of ketamine, 5 milligrams of midazolam, and 50 micrograms of fentanyl. That's 1 cc, 1 cc, and 3 cc's. Or correction, 3 cc's, 1 cc, 1 cc, for a total of 5. For sedation, administer 2 cc's IV and titrate to nystagmus. That's the twitchy eye thing. Then give 1 cc's as needed. Consider doubling the dose if you administer it intramuscular or intranasally. I recommend giving Zofran around this time, 4 milligrams IV over 2 to 4 minutes, or you can give it IM. The reason I give it is ketamine often makes people yak, especially when they're coming out of anesthesia. Give it before you want your patient to wake up. If you're going to go ahead and RSI this guy, take that anesthesia in a stick, give him the full 5 cc's, then follow it with a paralytic such as vecuronium, 20 milligrams IV. The onset will be less than 60 seconds, and the duration should be about 40 minutes or more. Now, some have said, what if you RSI and then can't get the airway? If we're going to RSI, we've already committed to securing this guy's airway. We're doing it because he needs an airway. So, one way or another, we got to secure this airway. Worst case, we do a cricothyrotomy. When securing the airway, the quicker the better. Now, when it comes to ketamine, I know some say to slow push ketamine over 60 seconds to prevent transient apnea or respiratory depression. Remember to abide by your treatment protocols. I've never seen apnea last more than 30 seconds when administering ketamine as a normal IV push. I've rarely seen apnea at all pushing ketamine. Remember to always monitor your patient's lungs, pulse, airway, and oxygen saturation at a minimum. Treat accordingly. I realize that mixing medications in the same syringe or IV bag may be controversial to some. There aren't many studies that have shown the safety and or efficacy of mixing medications, but one that I've read is Total Intravenous Anesthesia for Military Surgery by J. Restall et al., written in 1988. Some drugs come premixed. Ketofol, for instance, is ketamine and propofol premixed. In a perfect world, I'd rather run each medication in its own line, so if there are any reactions or a dose needs to be adjusted, I can adjust one without adjusting them all. With that being said, sometimes we have to do things in a less than perfect world. All of the drug mixtures I'll be discussing, I have seen and used multiple times. Okay, so we just sent this person for a ride. What kind of ride is this? Let's break down our drugs. Ketamine is a dissociative in larger doses. Some say that the patient knows what's going on but just doesn't care. I don't really buy this. That sounds more like an opioid response. If you give an anesthesia dose, this person's going on a ride. I'm talking about ride the dragon throughout the outer quadrants of space and time, an out-of-body experience. Think Timothy Leary and LSD. Turn on, tune in, drop out, baby. You younger folks may need to Google that. At higher doses, what kind of trip is the patient taking? That depends on their state of mind going into the trip. If I'm administering ketamine, this patient's probably having a bad day, i.e., they've had a significant traumatic event, or at least they've had their feelings hurt pretty badly. So we can expect a bad trip here. Remember, here there be monsters. Arr. With lesser doses, their sedative hypnotic state is influenced by their sensory input. Their visual, auditory, and sense of smell will influence this state. They can follow basic commands I've heard it described as being in another dimension, but having our dimension bleed over into it. Just to keep in mind, that's why we disarm before we administer ketamine. This is where other drugs come in. Midazolam is to help guide the patient to their happy place. It also helps alleviate muscle rigidity, which is common with ketamine. But this will not provide much pain relief. The fentanyl is to aid in treatment of pain. It's short-acting but works well with ketamine and reduces the amount of opioid and ketamine that you need to use to control the pain. Less opioid equals less adverse opioid effects, especially respiratory depression, apnea, and or a drop of the patient's blood pressure. As a lazy medic, anything that makes my life easier is great by me. Plus, if it's good for the patient, bonus. So now what? We have this person down and have their pain under control. How do we maintain that? We can just keep bolusing as needed, but that gets tiresome and it's more work for us. So we might as well do like real medical professionals and run a drip or an intravenous infusion. Let's start small. If you're within a 1 hour bubble or so, you can use a 1 hour bag. Remember, in a perfect world, we'd administer these drugs through their own lines, so you can adjust drip rates accordingly. But our world just became a surrealistic nightmare. So we'll keep this simple for now. Still, make sure you have at least 2 lines, IV, IO, or a combination of the two. During transport, you may lose one, and remember, Murphy is always out there. In a 50 cc normal saline bag, inject the anesthesia in a stick. In other words, 150 milligrams ketamine, 5 milligrams midazolam, and 50 micrograms of fentanyl. Using a 15-drop admin set, run at 0.5 to 2 milligrams per kilogram per hour. If you have trouble getting 50 cc bags, use whatever you can get and do the math for that volume. I know, math. Use your favorite drip rate app. For an 80 kilogram patient, run about 4 drops every 60 seconds for the low end and up to 12 drops per 60 seconds for your max. I recommend piggybacking this on a line of normal saline run to keep open, TKO. IV catheters often clot off when you run them this low. Remember, you knock your patient down to this level, to the level you wanted with the anesthesia in the stick. This drip is to maintain that level. So the dosage range goes from sedation to surgical plane. At this point, we would run our IV antibiotics. Most of us use a gram of Invans per day, but Ancef, clindamycin, Levaquin are all great drugs, and they're used for specific reasons. Choose whatever is appropriate for your patient. Follow your treatment protocols. This would also be a good time to run your second dose of TXA if your patient received or qualified for a first dose. And keep your patient warm. I don't care how warm the ambient temperature is. If your patient is shocky, they were probably cold. And a warm patient is usually a perfusing patient. The medications you give your patient will be more effective if the person is warm. Also, this is the part of the lethal triad that we can most easily affect. Warm the fluids you're running into your patient and actively warm them. This will make your life easier and, oh yeah, it's good for the patient. Remember, a surgeon focuses on the procedure. When acting as an anesthesiologist, you're responsible for staying focused on the entire patient. However long, you're responsible for their well-being. Now back to the scenario. So, what if we're someplace more remote with a longer evac time? We can mix up a 5-hour bag. Basically take 5 anesthesia in the sticks and inject that into a 250 cc normal saline bag. In other words, 750 milligrams of ketamine, 25 milligrams of midazolam, and 250 micrograms of fentanyl. Run this at the same rate as the 1 hour bag if you're using a 15-drop admin set. Don't forget to redose Zofran every 8 hours. So far, not too complicated, right? Remember that using local or regional anesthesia can reduce your need to sedate or to run anesthesia. It can also reduce the negative or negate the need for opioids. Using either ultrasound-guided and or a nerve stimulator, such as a Stimiplex, or simply anatomically placing regional anesthesia can be very effective. A multimodal approach is strongly recommended. Remember, to calculate the max dose for your patient and don't go past it, i.e., lidocaine 1% without epinephrine for a 70 kilogram patient. At 4.5 milligrams per kilogram, your max dose is 315 milligrams. That's total dose, so don't go past that. You can even dilute whatever agent you decide to use. A 50% solution is often just as effective. Volume is more important than concentration, especially if you don't do this every day and your placement may be a little bit off. If you have both the Stimiplex and the ultrasound, I would recommend getting placement with the Stimiplex and then confirming with the ultrasound. This will save supplies and make your life a lot easier, and it'll make the patient a lot more comfortable. All of this talk about anesthesia, but we haven't spoken about what to do if our patient is hemodynamically unstable and how this relates to our pain management. Our real concern with the unstable patient is the fentanyl. This will drop our patient's blood pressure and respiratory rate. In a shocky patient, this causes more work for us. Y no me gusta trabajar. For this scenario, remember, we're Johnny Trauma, so all compressible hemorrhage is controlled. However, our patient is still not doing so well. They may have an increased heart rate, decreased respiratory rate, BP, oxygen saturation. So as part of our damage control resuscitation, we're using fluids to try to maintain our patient's mean arterial pressure around 65. Like I said before, I'm not going to get into fluid therapies, but give your patient the appropriate fluid for their condition, crystalloids, colloids, or blood products. Fluid therapy is another podcast in itself. The formula for calculating MAP, or mean arterial pressure, is 2 times the diastolic blood pressure plus the systolic blood pressure divided by 3. Or for us simple trauma monkeys without fancy equipment, this means the patient is alert and oriented to person, place, and time with a radial pulse, warm hands, and warm feet. A MAP of around 65 allows perfusion to the organs, the brain, the lungs, the heart, GI tract, the kidneys, etc., but theoretically without resuscitating to bring the pressure high enough to blow clots. At least that's what we hope. With this patient, I strongly recommend running your drugs in separate lines. With a good regional block, you may only need ketamine. Now, with a hemodynamically unstable patient, we can administer fentanyl in small boluses, 12.5 micrograms. This way we can titrate to the patient's MAP. Basically, we'll resuscitate our patient until their MAP's around 65, then give a slow bolus of fentanyl. If the MAP drops, fluid resuscitate to bring them back to around 65. If the patient's in pain, give another bolus. Continue as necessary until the patient no longer drops their blood pressure or their MAP when they're administered fentanyl, or you turf them off to someone else. Another technique is to give your patient a bolus of ketamine in addition to their ketamine drip. Many of us like this technique because it's less likely to drop the patient's MAP. Remember to use care if the patient's been unstable for a while. We don't want to knock out their sympathetic nervous system. Damage control resuscitation is meant to deliver our patient as hemodynamically stable as possible to surgery. This will give them the highest possible chance of surviving the surgery and making a recovery. What if I have more patients than I have meds? How can I stretch my supply? I would look at what we're using the drugs for and how your patient's responding. Ketamine's our main drug. It's the last one I would look to skimp on. One thing you can consider is half dosing your midazolam, or better yet, why are we using midazolam? We want to put them in their happy place, right? So they have a good trip and we avoid reemergence syndrome and some amnesia. So we can give a dose of midazolam when we knock the patient down and another when we wake them up or after a painful procedure. Another idea is to cut back on the fentanyl and see how our patient tolerates the dose reduction. Or better yet, if you have a good regional block, you can do without the fentanyl altogether. If your patient is swallow oral meds, or if they have an NG tube in, a nasal gastric tube, or oral gastric tube, you can give them some Percocet or whatever oral medications you have to combine with your ketamine. You can also give an NSAID with acetaminophen and get about the same effects as Percocet. Just use with caution in a hemodynamically unstable patient, as NSAIDs can affect coagulopathy. Be creative and save your injectables for when things get worse, as they often do. What if you need to perform a surgical procedure or other painful treatment on your patient? If they're riding fine with ketamine and a regional block, you may want to give a bolus of midazolam and or fentanyl just prior to performing the painful procedure. If you need to knock your patient down to a surgical plane, try to minimize their time spent there. Patients that are intubated and kept on a surgical plane for long periods of time tend to have a poor outcome. Doctors Without Borders published a study on this. If you screw up your patient, you lose all your cool points. Don't lose your cool points, man. So, after all this nerd talk, let me mention medical supplies. Let's say we want to prepare to treat 2 patients. 1 is none and 2 is 1 and all that nonsense. In other words, if you have 1 and lose it, you have none. Always have a plan for contingencies. This is a material and labor-intensive event that you need to plan and train for. To hold a patient for 24 hours, you need 5 5-hour bags. 2 patients for 24 hours, you'll need 10 of those 5-hour bags. If you expect your evacuation to take longer, you'll need more. I cannot emphasize enough that you need to plan ahead and have adequate supplies and plan for multiple contingencies. To wrap this nerd fest up, remember that long-term pain management is both supply and labor intensive. It requires planning and training. We all like to imagine ourselves taking care of our teammates when we're at our best. Now imagine doing this when you're exhausted, both physically and emotionally. Imagine that you're injured yourself. Plan and train for those bad days, and you can make them a little less bad when they come around. And remember the 3 SF rules. Always look good, never get lost, and if you get lost, at least you look good. Good luck.
That's another one for the books. Make sure to go to the site, www.prolongedfieldcare.org. Post your questions, post your comments, make your voice heard. This is Dennis for the PFC Podcast, out.